Everyone. Thanks for joining. I'll just be waiting perhaps another 1 or 2 minutes for people to join, and we'll go ahead and get started. Thanks for joining today. I joined today's article authors, and I see, thank you so much, Dr. Cienciolo, Dr. Labaro, to be here today. I think it's always fun to have the authors here to talk about the study. So thank you so much for joining. And I guess as we are waiting for a couple more people, hopefully, to join, I will go ahead and come up with this little QR code here. And hopefully, I'm going to test with my phone, make sure that it's working. But you can scan the QR code and reply. I always like to use this journal club to have everybody's input and opinion on things. Oh, let me come back to that. So if you scan the QR code, or if you go on this web link, you should be able to reply to a question being, what is your main criteria to use the term PLN, protein-losing nephropathy?
Could you put the link in the chat?
Oh, yes, that's a good idea. Let me actually do that like that. Let's stop the share. I'm going to stop the share 2 seconds to put the link in the chat. Okay, hopefully this works. Let me actually open my poll to see if the responses are recorded. Perfect. Thanks everyone for adding your input here. Let me come back to my screen for people who just joined. If you can scan this little QR code and add your input on what is your main criteria to use the term PLN in your patients. And so I can right now tell you that we have 18% who replied proteinuria is present whenever UPC is repeatedly above 0.5. We have 9% UPC above 2. 55%, so basically the majority of people are saying proteinuria suspected or confirmed to be glomerular in origin. Probably 1% saying both proteinuria and hypoalbuminemia present. And somebody selected other. Let me see if there's something in the chat.
That was me. I said other.
Yes.
I think I would say it has not necessarily glomerular, like it would be proteinuria
Hmm.
that's confirmed to be of renal origin, but
Yeah,
that's my
yeah, yeah. And so that was sort of implying that we ruled out pre and post renal,
lower, yeah,
should I
pre and
say? Yeah,
yeah, yeah.
yeah. So basically, you would be more the answer, whatever proteinuria, as long as it's repeatedly above zero point 0.5 and it's renal in origin.
Yeah, that's how I would review it, but I don't usually use protein losing nephropathy as my terminology anyway. I think that's just the thing that veterinarians do.
Yeah, yeah. And this is something that I find kind of actually interesting, because this is a term that we use. Let me come back to my presentation here. This is a term that we, use, definitely. This is something that I've tried to see if at some point in the literature there was like somebody who gave a definition or, sort of um, have everybody talking about the same thing. And even going back to the guidelines on glomerular disease, they don't even talk about protein losing nephropathy, so this specific term. I found that very interesting when we had this symposium with human and veterinary medicine a couple of years ago in Boston. That's not a term that they're using at all in human medicine. And so, and I started to think about this term because we were discussing with a colleague and she was saying how she loves PLN while I absolutely hate PLNs. And basically, the idea was that we were absolutely not talking about the same thing. When I talk about, or when I say PLN, I'm really thinking about, unfortunately, the cases that we see way too frequently here in New England with in potentially anuric or at least severely azotemic patient with a UPC above 10 or 15 that we are trying absolutely everything in the world to save with therapeutic plasma exchange, with big guns immunosuppression. And no matter what we do, we lose them. Versus this colleague was talking about here, typical outpatient, cruising, not azotemic, with a UPC of 2.5, well controlled on telmisartan. So it is an interesting, you know, description or at least name of a disease that has a huge umbrella, I think. And so we'll talk a little bit about that in the study we're going to be talking about today. So I think that all these big terms that we are using are unfortunately reflecting very different scenarios. And I would be inclined to, as a group here, try to come up with at least a good definition that everybody talks about the same thing or use a different term. But this is why I'm not a huge fan of this protein losing nephropathy term. Anyhow, moving ahead, that's actually the oldest paper that I found talking about protein losing nephropathy. And it's funny enough, written, the first author was a person who is now really into the liver world. So I just found that interesting that even the oldest paper, coming up with this term is not necessarily giving a description or a definition of it. But back to our paper, today we will be talking about this article that was accepted end of last year in the JVIM, talking about the analysis of survival among biopsy-determined categories of kidney disease in dogs. The first author is one of our great previous resident here at Tufts that you can see here looking fabulous with his tiara, kidney tiara. That's the little picture that we take every time they run their first extracorporeal therapies. And so he was surrounded by this powerhouse from Texas A&M, Dr. Cianciolo, Dr. Hockamp, and Dr. Navidi, who are in charge of the biopsy center. There's also Dr. Rivera, who I think was a postdoc in Dr. Navidi's lab. Dr. Jeffrey was in this paper and was mainly in charge of the statistics, and Dr. Mary Labato was Dr. Schultz resident advisor. So I always like to have pictures on names and know who we are talking about. And we are very fortunate to have a couple of these authors here. So please don't hesitate to chime in and correct me if I say anything stupid or wrong. So in their introduction in this paper, they are sort of going back to how this sort of center was created and why it was needed to have a specific center where we can send our biopsies, because regular light microscopy was definitely limited. And so they are talking about this article that sort of came up with consensus recommendation for really the evaluation of renal biopsies for dogs with suspected glomerular disease. Probably everybody on this call is also aware of this fabulous Bible of renal lesion in proteinuria dogs that is free access online. So definitely a huge resources here that goes from normal anatomical glomerular to the different type of disease that can be described between and images of light, electron microscopy, and immunofluorescence. So definitely a great resource. They're talking about how they came up with this, cluster analysis to have the different category and have the different criteria for each category, and also highlighting that looking at that, if we were only looking at light microscopy, we would have a misdiagnosis of 22 of the 89 cases that they were presenting here in this study. So highlighting the importance of having this extra testing. And so what is very important to remember as well is that these kidney biopsies are classified in different diagnostic categories, but that should really be seen as a pattern of injury and not a specific disease, because that can be, each of these diagnostic categories can be the result of one or more of multiple etiologies, and they identify the portion of the kidney that is affected, and they guide us how to handle the case. They definitely have limitation, but right now they sort of represent the most accurate classification that can be used for the diagnosis and treatment of kidney disease in dogs. And so what do we have in the literature, or what did we have in the literature regarding the association between kidney biopsies findings and survival in dogs with kidney disease? The studies up until now first were not very, we don't have a lot of them, and the majority of them were always focusing on one specific biopsy result or finding. So we had this quite older study now on glomerular amyloidosis that had a median survival time of 5 days. We had more recent studies on FSGS that had a median survival time of 258 days. There's 2 papers on renal maldevelopment in boxer dogs that had a median survival time between 0 to more than 5 years, so sort of emphasizing the differences here, or median age at time of euthanasia of 16 months, going from 6 to 79 months. For the paper that we have on membranous nephropathy, it will be further discussed in this paper, but it's also an older paper and that may have been sort of misdiagnosed, but that's a paper that we have that had a range of the follow-up through postmortem between 2 days and 3 years. So emphasizing here that maybe we had different categories that were diagnosed as membranous nephropathy. We had this paper from 1996 looking at what they used to call at that time protein-losing glomerular disease that only had light microscopy for the diagnosis of these cases. And so for these cases, they had a median survival time of 28 days. And a more recent paper from the UK, specifically on immune complex glomerulonephritis, that had a follow-up time of 633 days and a median survival times of 267 days. So we'll go back a couple of times to this more recent paper. So that's what we had between the finding and survival in the literature. And so regarding the association that we used to have between this time the clinical pathological variable and the survival, previously associated with survival, we had serum creatinine and albumin, a decreased body condition score, presence or not of nephrotic syndrome, the degree of UPC, fibroblast growth factor 23, and a systolic blood pressure. But some of these factors, the studies were really inconsistent regarding their association with survival. And so this is the idea of this study, to sort of look at these two different things, the clinical pathological variable and the different biopsy finding, and see their relationship with survival. So what did they use? They basically used the kidney biopsy submitted to their group between 2008 and 2018. And they also used the data that is part of their form and submitted by the clinic, being the signalement, the date of biopsy collection, and their most recent creatinine, albumin, UPC, and blood pressure. All biopsies were processed for light microscopy, electron microscopy, and immunofluorescence. And the biopsies were classified into these 26 different categories that you can see on the right, based on the criteria highlighted by the WSAVA Renal Pathology Initiative. And so you had the three big categories being affecting the entire kidney, or just glomerular disease or tubular disease. And so each of the glomerular were subdivided again into immune-mediated or non-immune-mediated. And so that was their case selection. And regarding the follow-up, the information was obtained either by electronic medical record or communication with the primary care or referring veterinarian or the owner, or combination of all of them. And the minimum follow-up information had to be the status of the animal, alive or dead, and if deceased, to have the date of death, and whether or not the dog was euthanized whenever possible. And so the survival was the number of days from the biopsy acquisition to the death, or the last known date the dog was alive. And for the majority of them, the follow-up was at least 5 years post-biopsy. Regarding the statistics, it was quite typical statistics with normal distributed values summarized as mean and standard of deviation, non-normal distribution as median, and interquartile range. Creatinine, UPC, and albumin age, they were stratified into different groups to determine the survival time, and these groups were based on the clinical judgment of the author. And then for the univariate analysis, they used the Cox proportional hazard method. And for the multivariate, they used the lasso method to sort of simplify the model. And what was important here is for the comparison of survival between the diagnostic categories, they used the highest number of dogs as a baseline, and that was the FSGS group here. Significance was below 0.5, and the animals that were lost to follow-up before death were censored after their last known date of survival. And so for the results, they had 1,439 biopsies, so each from a unique animal, so as many biopsies as animal, and the age ranged from 1 month to 16 years with a median age of 7 years, and 78% of them were above 4 years old. They had more or less the same amount of male and female. Regarding the breed, 84% were purebred, but they had more than 100% breeds represented, and the most common were mixed breeds, followed by the retrievers, Labradors and Golden, the Yorkies, and the miniature Schnauzer. This is supposed to be already part of the results. So that was for the results of the demographic. Then here, forget the titles, that's the results of the clinical pathological data. So you can see that for the patient, the cases that had the highest UPC were part of the non-immune mediated glomerular disease, being amyloidosis, non-amyloidotic fibrinolytic and the collagenofibrotic. So that was the highest UPCs. The lowest UPCs were, not surprisingly, the tubular disease and the juvenile nephropathy as well. For the highest creatinine, it was the sclerosis categories, the arterial-nephrosclerosis and nephrosclerosis, and also the sclerosing immune complex glomerulonephritis. While the lowest UPC, the lowest creatinine in these cases were the non-immune-mediated glomerulonephritis, being the GB hemopathy, lipidosis, lipid emboli, podocytopathy, and the mesangial-proliferative glomerulonephritis here in the immune complex mediated. For the cases with lowest albumin, it was basically all these categories here in the immune complex glomerulonephritis, being the membranous, membranoproliferative, and the mix of both of them. And the cases, the youngest cases were, not surprisingly, the juvenile nephropathy and also the collagenofibrotic diseases here, while the oldest were the thrombotic microangiopathy, FSGS, GMopathy, and lipid emboli. So that was the results of their clinical pathologic data. Regarding the UPC, they didn't have any specific number that separated tubular and glomerular. That would unfortunately be too easy. But they definitely had sort of a tendency. Obviously, the higher the UPC, the more likely it was to be glomerular. And for the glomerular category, 93% of the cases had a UPC above 2, and about 2/3 had a UPC above 5. While in the tubular category, the majority, 63%, had a UPC below 2 and 13% a UPC above 5. And only 2 of these cases in the tubular category had a UPC above 10. And so this is the creatinine, albumin, and age that we talked about for the different categories. There was like a notable overlap in the signalement and the biomarkers among this different category, but there was a trend that we've been talking about. Regarding the follow-up and survival, the information was obtained for 654 out of the 1,439 biopsies, so 45%, and the follow-up until death was available for 27% of them. But the good thing is that the cases with follow-up had a similar signalement, biomarker data, and distribution of disease categories than the full data set. And for this entire population, the median survival time was 608 days. And for the dogs with the follow-up until death, we had a median survival time of 207 days. And so regarding the association between this clinical pathologic data and the survival, we had the patient with the highest median survival time with a creatinine below 1.4. When we talk about the creatinine, while the cases with a creatinine above 5 had really a much shorter survival time with a median of 10 days. Here, the categories, again, were sort of splitted according to the author. So that could be sort of looking at the grading probably of the AKI subgroup here, although we don't have like a differentiation between above 5 or above 10 in the creatinine here, but definitely not a good median survival time when they had a creatinine above 5. Regarding the albumin, we had a survival time higher in dogs with an albumin that was higher or equal to 2.5. For the UPC, they were not able to have a median survival time for below 0.5 because there was not enough in this group, but they were able to have at least the lower quartile survival time, and so it was much lower for the UPC below 0.5 than the UPC above 15. And because the blood pressure was not frequently or inconsistently reported, they did not include this data with the association with the survival. Regarding the disease category this time and the survival, they had 14 out of these 26 categories that had a follow-up on at least 10 dogs. And so they focused on these 14 categories here that you can see on the right. And so for these 14 categories, the median survival time was 596 days, which is more or less like the same as the entire population with 608 days. And the longest median survival time in this 14 was podocytopathy with 1,709 days, while the shortest was amyloidosis with 76 days. When looking at the odd ratio of spontaneous death in the univariable analysis here, again, as we discussed in the material and method, the FSGS was chosen as a baseline because it was the largest number of cases and also because the median survival time was similar to the entire population. So that was the baseline, and each of these categories were then compared to this baseline to calculate hazard ratio. And so with this univariable analysis, amyloidosis had a significantly increased hazard of death compared to FSGS at 2.75, while the juvenile nephropathy, podocytopathy, and membranous glomerulonephritis had a significantly decreased hazard of death. The other categories were not different compared to FSGS. So that was for the univariable analysis. Looking at the multivariable analysis, again, FSGS was chosen as baseline. And amyloidosis was, again, the only one that had a significantly increased hazard of death. And looking at the clinical variables, when we had an increase in creatinine, increase in age, and increase in UPC, this was also associated with an increased hazard of death, while an increased albumin above 2.5 was associated with a decreased hazard of death. And for the multivariate analysis, also associated with a decreased hazard of death were the categories of podocytopathy, mixed membranoproliferative glomerulonephritis, membranous glomerulonephritis, and the mix of both. So that was for the multivariate analysis compared to FSGS. And so in their discussion, they are talking about their overall median survival time of 608 days. And comparing to the FSGS, we know that amyloidosis, increase of creatinine, age, and UPC is associated with an increased hazard of death, while an albumin above 2.5, podocytopathy, membranous glomerulonephritis, membranoproliferative glomerulonephritis, and the mix of both of these entities were associated with a lower hazard of death. And so when we look at the survival of different categories of kidney disease, and what do we have in previous studies. Circling back to this study we talked about in the introduction from 1996 of cases of protein-losing glomerular disease. At that time, they had a much shorter survival time of 28 days. Obviously, it was a different population because that was from a single university versus all the different places of private practices and university, even from different countries, going to the IVRPS. They had a similar median survival time for amyloidosis, 31 days, and what they used to call back in the day idiopathic glomerulonephritis. But in this study, they had no correlation between survival time and creatinine, albumin, or UPC, though we have much smaller population in this study. And so the discussion here is, at that time, that was mostly light microscopy, so it limits the comparison of outcomes for these different diagnostic categories. And the question here is also, do we have now an increase of awareness of this disease? Do we have an earlier diagnosis than back in 1996? And is it the reason why we may have an improved outcome, when we compare the 608 days with these 28 days back in the days? The question is also the evolution of the treatment. That being said, I'm not sure that the treatments that we have could really make such a difference between 28 days and 600 days, but that could have been part of the reason, with the different RAS inhibitors that we have, calcium channel blocker, anti-thrombotic, the different diets that can be especially formulated, and also the immunosuppression that we have available here. So a discussion about why we may have such a discrepancy in survival time between this study in 1996 and the current study. Talking about the more recent study from the UK, they had sort of a closer, more matching median survival time here of 267 days, still much shorter, but already better than the 28 days from back in the days. In this study, they had the light microscopy, electron microscopy, immunofluorescence as well. But the downside was the immune complex glomerulonephritis were all grouped in one category. So we couldn't really differentiate between these categories. While we know from this study that they can definitely have a different outcome. For example, the median survival time for membranoproliferative glomerulonephritis in this study was 266 days versus 1,211 days for membranous glomerulonephritis. In this study, they had only 27% of their biopsies diagnosed with immune complex glomerulonephritis versus the 48% that we have from the US study. One of the suspicion is that perhaps because they don't have diseases associated with immune complex glomerulonephritis, such as Dirofilaria immitis and various tick-borne diseases, that may be the reason why they see less immune complex mediated glomerulonephritis. In this current study, the immune complex glomerulonephritis represented 38% of the population, but that was also not a study limited to glomerular disease. So that may be the reason why it was a little bit lower than the 48% previously reported. And so regarding or discussing the different results for each disease category, amyloidosis, unfortunately, as previously described, is associated with a poor outcome. The median survival time was 76 days here, and so similar to previous report, between 531 and 141 days. But it was important to highlight that some of these dogs could have a prolonged survival, and 25% of them were alive at 299 days. So it's not necessarily a fatal disease, and they even had a maximum survival of 1,471 days. So the question here is always the question of, we know that it's a disease that is perceived to have a poor to grave prognosis based on prior studies, so that may influence the timing of this euthanasia. And now that we see how different the survival can be within the same category of amyloidosis, the question is, do we have subtypes like in human medicine that are not clearly established in our dogs? And we at least know that probably the hereditary amyloidosis of the Shar-Pei is probably a different entity than amyloidosis in other breed. But in this study, they didn't look at the breed differences. We unfortunately have not a lot of great treatment options for amyloidosis, so that may be one of the reasons for this poor outcome. And it is also a disease associated with chronic inflammation and neoplastic conditions, so comorbidities might also affect the survival, and the comorbidities were not reported in this study, so we may have had here a difference in survival time related to comorbidities that were not highlighted. So that was for the amyloidosis category. For the FSGS, what we used to have were mainly these two studies here, one looking specifically at FSGS, and the other one having FSGS as part of the data. And in this specific study we're talking about, that was the most common diagnosis, 18% of all submitted cases, and that was also 22% of the cases that had a follow-up. And that was consistent with the previous prevalence of the previous studies. And for this disease category, the median survival time was 536 days. And creatinine, albumin, and UPC age were all associated with survival, and that was not limited to FSGS. For the membranoproliferative glomerulonephritis and the mixed version of it, we don't really have great previous study or data in veterinary medicine. They are talking about what we know in human, and MPGN being a general pattern of injury, as we discussed in veterinary medicine, characterized by hypercellularity and subendothelial immune deposits rather than a specific disease. So really this pattern of injury we talk about. And in human medicine, they have different subtypes that can be primary or secondary, and can be associated with certain infection and autoimmune disease, but can also be idiopathic. And the response to treatment and outcomes can really vary. And that's sort of what we can see in your cases as well. In this specific study, half of the immune complex glomerulonephritis were membranoproliferative or a mixed membranoproliferative glomerulonephritis. And the significance of where these deposits are located is unknown at this point. But we know that mixed MPGN and MPGN had a significantly decreased hazard of death compared to FSGS. And the mean survival time for MPGN was 694 days, while mixed MPGN was 266 days. And what was even more interesting was the difference between the upper and lower quartile survival time, because these diseases had really kind of a lower quartile survival time of between 10 to 76 days, and a quite high upper quartile survival time. So it really shows the big discrepancy even within this category, and also highlights that if the dogs are surviving the initial diagnostic period, they may have a relatively good prognosis. MPGN is also in our dogs thought to be associated with certain infectious disease. And so one of the questions is, are some of these dogs responding well to the treatment? And this is why we can see them having a much longer survival time. So definitely here a question mark. Regarding membranous glomerulonephritis, what we know in human is that it's most commonly idiopathic, but that can also be associated with infection, cancer, or side effect of certain drug. There is unfortunately no consensus on the best approach to treatment, and the outcome can also vary widely. Having some patient having spontaneous remission, while another cohort of patients can experience progressive loss of kidney function, and that leads eventually to kidney failure. And in humans, there is a recent advancement, and they are looking at different data with different biomarker that sort of help predict the outcome and guide the treatment decision in this patient regarding where they fit within this category. And in our dogs, again, the significance of the variable location of deposit between subepithelial and subendothelial is really unknown in our dog. Something that is important to highlight, circling back to the study we were talking in the introduction, membranous glomerulonephritis has likely been overdiagnosed based on capillary wall thickening when the studies were limited to light microscopy. So we really have a difficulty here to compare with previous data because that may have been an incomplete or an incorrect diagnosis. And for this specific category here in this study, they had a median survival time of 1,211 days for membranous glomerulonephritis and 966 days for the mixed membranous glomerulonephritis. And so highlighting again, like as in human, these 14 diagnosis categories that they are talking about really represent an heterogeneous group of disease. It is really a pattern of damage. It is not a specific disease. And that probably explain why we have such a variation in outcome within an individual group. The typical example would be membranoproliferative glomerulonephritis. 25% of them died within 10 days, while the other 25% were still alive 6 years after the biopsies. So something extremely interesting that I see way too frequently. We are unfortunately in our area seeing a lot of this 25% who die within 10 days, no matter how hard we try, no matter what we do. So it is just extremely interesting, and I would love to further look into that, why we have such a discrepancy. The other thing was that 4 out of the 5 of the diseases that we talked about had a lower HR compared to FSGS. And so only mesangial proliferative glomerulonephritis did not have a significant decrease in hazard ratio. And so the question is, do we have more treatment available for these diseases? And so because it's immune mediated and we have immunomodulation, is it the reason why they have a better outcome than FSGS? So also a question mark here, obviously. But there is definitely a broad diversity of presentation and likely broad diversity of underlying cause for each of these categories. So it is difficult to make a prognostic prediction, even when we know under which category they are. And in human medicine, the guidelines, of course, take into consideration this biopsy category, but they use much more than that to come up with treatment plan. They also look into ethnicity, age, if there is any presence of infectious disease, and the level of certain antibodies. So a better understanding of each of these individual diagnostic category is going to be needed before we can make prognostic prediction or any tailored treatment recommendation for each individual dogs. Again, the clinical variable here definitely influenced the prognosis, and so they should be incorporated into the prognosis when we talk about diagnostic category. Also take in consideration where we are with creatinine, albumin, what is the age of our patient. So that should all be incorporated into the clinical assessment of dog with kidney disease. And there's probably even more clinical variables that should be eventually part of this package that we should create to come up with treatment recommendation. This discussion ends up with, of course, the limitation of the study being a retrospective study. And also the results are probably most relevant to the studied population. So we are talking about dog with a suspicion of glomerular disease, typically under the care of a small animal internal medicine specialist. So this is quite a specific population. And the dogs were probably biopsied at different points in their disease progression. So that leads to the difficulty of really knowing the true outcome with this specific study device. Something they highlight is that 40% were not azotemic at the time of biopsy. So that was probably an early diagnosis in the majority of the cases. And of course, because it is retrospective and it is based on the biopsies, we had various treatments and the treatment strategies within this 10 years of inclusion period may have changed. So of course, there was a big variation here. And some of the follow-up information was gathered from owner recollection, so we may have not accurate date of death. And euthanasia was common. So the factor other than severity of kidney disease may have influenced the date of death in some cases. And the biomarker information reported by the submitting veterinarian on their on the biopsy report, we never know the proximity in time to the biopsy collection. It's different analyzer. It's only one time point. So typically regarding the creatinine, we don't know if it is a creatinine in the middle of an acute kidney injury, or are we talking about a stable CKD? So obviously a limitation here. And the blood pressure were not analyzed because there was just a lack of standardization in measurement technique, and it was not always reported. And they were also not aware of if any antihypertensive medication had been initiated. And also important to highlight that sometimes just the pathology classification of these biopsies were difficult to make in some of these cases, and they may have moved from one category to the other. And so in conclusion, they report quite a relatively long median survival time for dogs' biopsies for suspicion of kidney disease compared to what was previously reported. They reported a diagnostic category, age, and clinical pathologic variable are contributing to the risk of death. And there was a wide range of possible outcome for an individual dog within a different category. So we should really be, we should be cautious in predicting the outcome for any of these disease category, because even within each category, there may be a wide range of outcome. And I think that's all I had for you today. Let me see. Does anyone has any question? Or let me see, Dr. Cianciolo said something in this chat. So she is saying she would love to have serum C3.
I'm working on it.
and even C4. You're working on it? Great.
I am.
Level as biomarker. I wonder if that might be predictive for the MPGN cases that have short survival time. So yes, that would absolutely be lovely, because we're dying, especially with the cases that we see here at Tufts. This is really hard to go through all of that, to go through all these expenses, of that may be cases that require extracorporeal therapies, the time that we even get the biopsy results back, and having always this hope that maybe if we are able to go through this crisis, we may get to this lovely 6 years of survival, but it's always a huge, huge commitment from the owner, financially, emotionally. And we unfortunately see a lot of them that are crashing and burning within 10 days. So if at some point we have a biomarker able to tell us it's worth the fight or don't spend your money, and also trying to have a better treatment options for these cases, this would be absolutely lovely.
Yeah, Rachel and I have talked about this, and this is actually on my massive to-do list. I'm not necessarily saying like develop an antibody or diagnostic test independently, but starting first with some of the commercially available assays that are available, and go from there. And so I have that hopefully in my arsenal maybe soonish.
That would be lovely. And I would be absolutely thrilled to be part of any sort of further work on this, because this is something that we see a lot, and something that I wish one day we'll have a better, diagnostic tool, treatment tools, because these are terrible cases.
Yeah, absolutely. First thing we have to do is optimize, or, make sure that the ELISA that we're looking at works, and actually works in our animals. And so we're playing with, well, I've been discussing this with my research associate, and so this is hopefully something we can figure out soon. And then once we have that, then we would be, moving forward from there. But we have to get it all optimized first.
This is extremely interesting. Any question from the rest of the team here?
Just a comment in case somebody else saw it. I haven't read the article yet, but I just saw it's in, I think, the New England Journal of Medicine. It may have been in ASAN, the Society of Nephrology, but it was one of the new, NAB drugs that was being tried in people with, I think it was an immune complex, or at least a membranous nephropathy, that was showing promise. But I pulled it aside to read, but I don't know if anyone on the chat here saw that article and took a look at it. Okay, I guess I better read it now and come back to everyone.
One thing I'll add
Yes.
is just you were mentioning how like Tufts sees maybe a different population. I don't believe this made it into the final paper, but the FSGS was not the most common diagnosis based off every state, which was interesting. And like New England definitely had more like of the immune mediated and MPGN. So there's definitely geographic differences, which I thought was interesting. And I don't think that's in the literature right now.
And I don't believe that they're necessarily all triggered by a tick-borne disease, or we don't always, like it tends to be it's because we see more tick-borne, but it seems to be more complicated than that. So just very interesting.
Yeah, I would agree with you. We see the bad proteinuric AKI patients that are just miserable to manage. And whether we're still included as the southern part of the Northeast corridor of the US or not, I don't know. But we see plenty of them. And I don't really think that there's a strong association at all with at least the rickettsial disease that we treat and that we test for. And very often their NC state panels will be unrewarding, and doxycycline trials will be not effective to provide a clinical cure, certainly, or even clinical improvement. So whether there is something regional or whether people are just adequately trained and prepared to identify those cases too, it seems like the more you talk to people, like the more that they recognize, like, oh, yeah, we didn't do a UPC on that patient that had an AKI and became anuric and overloaded in the hospital. Maybe we should have, or recognizing like it might have been 3 or 4, and that's still maybe really bad, and despite the creatinine being 10. So I don't know how much of it is understanding and an awareness of it versus there being truly a regional difference. But yeah, I mean, these cases are the worst to manage when they're that sick and in the hospital. They're really frustrating, especially not knowing exactly what the trigger may be.
And then I think, JD, you have to be a little careful about doing UPC on a very acute case when it may not be representative. So I'm curious how you clinicians decide when to do the UPC when it is acute and you don't really have stable disease to know that it's going to be a representative UPC. What are your thoughts?
Yeah, I think that's a great point, Mary. Not only is creatinine not in steady state, but you're probably going to have a significant amount of tubular component to the proteinuria, or at least potential for, if you're having significant tubular acute kidney injury. And the GFR might be in the toilet. And so you might not have much filtration. You also might have tons of tubular obstruction. So the tubules that have lots of protein that have snuck through and have created these casts might be obstructed, and that's what's also leading to your decreased GFR. But that protein might not make it out to the urine because it's obstructed the entire nephron. So some of it is just that you see this patient that is oliguric, they are not tolerating their fluids very well. They have a maybe a more modest UPC, where I think some people would write that off and say, oh, that's just going to be all secondary to the AKI. But you look at everything and you might say, I think this might be glomerular disease that's the trigger of the AKI, and it's just being miscategorized because that UPC might not be as robust because of all those reasons. And so I think it would still be on our radar. And I think they just fit that picture. You know, you can kind of smell those patients. You just have a good, I mean, that's not true. They don't have a specific odor, but like you just have a gut feeling that here's a patient that seemingly has an AKI. They have no history of chronic disease. They have no evidence of toxin exposure, and they're hospitalized, and their kidneys might look normal. Maybe they're a little bit big, you know, look like your classic AKI, but partly that intolerance of fluids, that the edema that they often will get with the administration of fluids, like some of those clues clinically raise the concerns to me that this is probably a patient with primary glomerular disease. And, you know, we probably don't biopsy all of those patients, but probably a handful of them. And it's hard to even think of one that's come back not as immune complex. Like if it's amyloidosis, they just don't act that way. They usually have a slower progression. Yes, they can have an acute worsening, but they're still going to be eating generally when their creatinine hits 4, and they tend to be a bit more stable. These are patients that are just really quickly circling the drain. And I think clinically there's a different phenotype that's there, I don't think I'm doing an adequate job of really explaining it, but I think for those of us that it's on our radar, you do get that gut sense that you're like, I think this patient's going to have bad glomerular disease and it's not doing well. We might just need to empirically immunosuppress because it's not even in a good place where we could biopsy. And a lot of those patients just don't pull through despite all your best efforts. I don't know if others have different opinions on the presentation or those types of cases, because Mary, you're right, the UPC does not necessarily serve as the best predictor of not only the severity of the glomerular disease. Sometimes you can even just make people not suspect it's glomerular in origin, but I think clinically those patients do often share a lot of common features.
Yeah, I would second all that. I would say that being in Colorado, we don't see a lot of tick-borne related disease. I mean, it's very few, and the cases that I've biopsied that have come back as immune complex have presented for various kind of etiologies leading up to their AKI. I've had some dogs come in with respiratory disease, some Frenchies with, you know, allergic skin disease and things like that. So I do have some questions as far as anything that's immune mediated in a patient is at a risk factor for developing immune complex disease for these patients, despite, you know, our extensive testing for infectious diseases that, you know, we strike out on. You know, how do we target those patients that have maybe something else going on as far as their systemic disease is considering?
Great. Thanks so much, everyone, for chiming in and sharing your experience. I think it's really, really interesting. Any other comment or question? Great. Well, thank you so much, everyone, for being here today. And I wish everyone a great rest of your day.
All right. Thank you.
Emmanuelle.
Bye, everyone.